Andrew, half the internet treats fish oil like a 30-day reboot for the brain, joints, and heart at once. If we ignore the hype reels, what is the adult supplement claim that still holds up under medical evidence?
The durable mark is triglycerides. EPA and DHA from fish oil have the strongest practical adult supplement signal around lowering elevated triglycerides, especially when doses and products are medical grade rather than random soft gels. That is a blood fat marker win, not proof that every heart, mood, or joint claim rides along for free. A recent multimodal look in diabetic kidney disease put numbers on that lipid effect. In a meta-analysis of 12 randomized trials with a few hundred participants, Omega-3 supplementation cut triglycerides by about 0.27 millimoles per liter, nudged systolic pressure down a few millimeters, and raised HDL a little. Kidney filtration and albumin to creatinine did not clearly move, so the win stayed metabolic, not a kidney cure.
Then why do so many explainers jump straight to brain cells and inflammation as if those were the proven frontline benefits? Is the membrane story the mechanism, or is it being sold as the clinical outcome?
Right split. EPA and DHA settle into cell membranes and feed pathways that make less aggressive inflammatory mediators. That is real cell biology, and pharmacology explainers love that cartoon for a reason. It explains why researchers keep testing mood, joint comfort, and brain aging, but each of those still needs its own dose, population, and hard endpoint. Biology opens the door. It does not finish the trial.
If I already eat salmon a couple of times a week, am I answering the same question as someone swallowing a high EPA capsule for high triglycerides? Or are those completely different jobs?
Different jobs. Federal dietary guidance still points adults toward roughly 8 ounces of seafood a week for EPA and DHA from food. That pattern is about overall diet quality. A retail soft gel is a convenience product, and a prescription omega-3 is a dose therapy for high triglycerides under medical care. Same fatty acid family, 3 different questions. And plant ALA from flax or walnuts is another lane. Conversion to EPA is limited, and DHA production is nearly absent in practice. So a flax bottle is not a stealth fish oil prescription. If the target is blood EPA or DHA exposure, you need seafood, algal oils built for that, or an EPA/DHA product, not wishful conversion math.
So when a video says fish oil is basically heart medicine for everyone, is that overselling a qualified claim? Where does prevention evidence actually sit once we leave the triglyceride lab value?
It sits in layers. An American Heart Association scientific advisory on omega-3 supplements focuses on large trials with clinical cardiovascular endpoints and is careful about who might benefit, especially around secondary prevention contexts, not a blanket primary prevention capsule for the whole population. FDA has also allowed only qualified language around EPA and DHA for certain blood pressure and coronary risk discussions, which is the opposite of an unrestricted cure claim.
Before we go deeper on who benefits, where does bleeding fit? If someone is on anticoagulants or heading toward surgery, is fish oil still a casual add-on at the pharmacy counter?
The people most likely to see a meaningful triglyceride drop are adults who already have high triglycerides and are managed with Lifestyle Plus, when needed, prescription-strength EPA or EPA/DHA products. If your levels are already ordinary and your seafood intake is solid, another drugstore bottle is often answering a question your blood work never asked. Even outside cardiology, triglyceride control shows up as a practical side story. In young adults on low-dose isotretinoin for acne, adding about a gram of fish oil was non-inferior for clearing acne and associated with smaller triglyceride rises and better skin hydration signals than isotretinoin alone. That is not a heart trial, but it is another reminder that EPA/DHA often earn their keep on lipid markers. Higher dose programs also need rhythm context. Atrial fibrillation signals have shown up around some intensive omega-3 regimens, which is why clinician oversight matters when doses climb far above casual soft gels. Pair that with product quality variability in retail oils and high-dose self-experimentation is a poor substitute for supervised care. Judge the adult use case with fasting triglycerides and the rest of the lipid panel, not with a mood diary or a viral 30-day challenge. If the product was meant to move triglycerides, recheck the labs after a clinician set interval. If nothing budged and diet already includes fish, expectations should shrink instead of the dose endlessly climbing.
What about fish allergy, or a messy medication list that already includes blood thinners and antiplatelets? Is the default answer just ask first, or is there a cleaner rule of thumb before anyone doubles a soft gel?
Blood markers can move without performance fireworks. In young men, 8 weeks of an EPA structured lipid raised the serum EPA to a arachidonic acid ratio more than a simple physical mix. Yet muscular endurance and fatigue measures did not beat the comparator. So a prettier fatty acid ratio is not automatic gym proof. Surgical immunonutrition literature makes a related humility point. Combined formulas with arginine, nucleotides, and omega-3 fatty acids may reduce some post-operative wound infections, but isolated omega-3 supplementation alone has not shown that benefit. Stacking fish oil onto every medical problem because it appears in a blend is how indication creep starts.
So the fair takeaway is that fish oil earns its keep when triglycerides are the target, food and prescription lanes stay distinct, and big heart or brain promises get demoted until their own evidence shows up. Did I compress that cleanly enough for someone staring at a drugstore shelf tonight?